This is Ryan. He's 16 years old, quiet, kind, and always curious about how things work. But as he got older, Ryan noticed something that made him feel different. Ryan was taller than most of his friends, but he felt awkward in his own body. His shoulders were narrow, his voice hadn't deepened much, and he wasn't developing muscle like the other boys. He felt embarrassed changing for gym class. Some classmates made comments about his chest, and Ryan started avoiding sports altogether. At home, Ryan finally opened up to his mom. He shared how he felt off, not just physically, but emotionally too. He was often tired, had trouble concentrating, and felt more anxious than usual.
I'm proud of you for telling me. Let's go see the doctor. We'll figure this out together.
The doctor asked questions about Ryan's development, energy levels, and mood. After a physical exam, she suggested some blood tests and referred Ryan to an endocrinologist.
There are a few possibilities here. Let's look at your hormone levels and chromosome profile, just to be thorough.
A few weeks later, the results came back. Ryan had an extra X chromosome. His doctor explained that he had Klinefelter syndrome, a condition that affects about 1 in 600 males, but often goes undiagnosed.
People with Klinefelter syndrome are born with an extra X chromosome XXY instead of the usual XY. This can affect physical development, fertility, learning, and hormone levels. Many don't even know they have it until puberty or adulthood.
Ryan met with a team of specialists, an endocrinologist, a counselor, and a speech therapist. He started testosterone therapy to help with energy, muscle development, and mood.
With the right support, you can live a full, healthy life. Klinefelter syndrome is just one part of who you are.
Ryan began to feel more like himself. His confidence grew. He joined a local robotics club, started playing guitar, and even helped his school start a support group for teens dealing with medical conditions. Ryan's story shows us that understanding your body, and asking questions, can lead to answers, healing, and strength. Klinefelter syndrome may be rare, but with awareness, early diagnosis, and support, those who have it can thrive. If you or someone you love is experiencing delayed puberty, low energy, or emotional changes, talk to a doctor. You're not alone. Klinefelter syndrome is a genetic condition affecting males, characterized by the presence of one or more extra X chromosomes, most commonly resulting in a 47XXY karyotype. This chromosomal aneuploidy disrupts normal male sexual development and leads to a spectrum of physical, developmental, and reproductive abnormalities. KS is the most common sex chromosome disorder in males, with varying degrees of phenotypic expression depending on the number of extra X chromosomes and mosaicism, e.g., 46XY/47XXY. Prevalence: Klinefelter syndrome affects approximately 1 in 500 to 1,000 live male births, making it the most common sex chromosome disorder. Only 25–40% of cases are diagnosed, often in adulthood during infertility evaluations or incidentally via karyotyping. Age of diagnosis: prenatal, increasing due to widespread prenatal screening. Childhood, rare, unless developmental delays or physical signs prompt testing. Adulthood, common, especially during infertility workups or endocrinology referrals. Variants: mosaic Klinefelter syndrome, 10%, and higher-grade aneuploidies, less than 1%, are less common. Klinefelter syndrome occurs globally with no significant geographic variation in prevalence, as it is a sporadic genetic condition. Higher in developed countries with access to prenatal screening, genetic testing, and infertility clinics, e.g., North America, Europe, Australia. Lower in low-resource settings due to limited healthcare infrastructure and awareness. In some regions, stigma around infertility or developmental disorders delays diagnosis. Access to testosterone therapy or fertility treatments varies widely, impacting outcomes. Klinefelter syndrome is caused by nondisjunction, an error during meiosis where chromosomes fail to separate properly, resulting in gametes, sperm or egg, with an abnormal number of sex chromosomes. Key points include: approximately 50% of cases result from nondisjunction in maternal meiosis, often associated with advanced maternal age, and 50% from paternal meiosis. Chromosomal variants. 47XXY, the most common form, 80–90% of cases. Mosaicism, e.g., 46XY/47XXY seen in 10% of cases, often resulting in milder symptoms. Higher grade aneuploidies, e.g., 48XXXY, 49XXXY rare, associated with more severe phenotypes. Risk factors include: advanced maternal age is a minor risk factor, but Klinefelter syndrome occurs sporadically with no clear hereditary pattern. Klinefelter syndrome is not typically inherited, it arises de novo during gamete formation. The extra X chromosomes in Klinefelter syndrome disrupts normal male development through several mechanisms. X chromosome inactivation. Normally, one X chromosome is inactivated, body formation, in females to balance gene expression. In Klinefelter syndrome, the extra X chromosome is partially inactivated, but some genes escape inactivation, leading to overexpression of X-linked genes. This disrupts hormonal and developmental pathways. Testicular dysfunction. The additional X chromosome impairs Sertoli and Leydig cell function in the testes, leading to reduced testosterone production, hypogonadism. Impaired spermatogenesis, resulting in azoospermia or oligospermia, infertility. Progressive testicular fibrosis, especially after puberty. Hormonal imbalance, low testosterone and elevated follicle-stimulating hormone, FSH, and luteinizing hormone, LH, levels due to impaired feedback in the hypothalamic pituitary gonadal axis. Developmental effects. Overexpression of X-linked genes affects brain development, skeletal growth, and metabolic regulation, contributing to cognitive, physical, and systemic features. Klinefelter syndrome presents with a wide spectrum of symptoms, varying by age, severity, and mosaicism. Many cases remain undiagnosed due to subtle or absent symptoms. Prenatal and neonatal period. Often asymptomatic, but prenatal screening may detect 47XXY via amniocentesis or chorionic villus sampling. Mild signs: hypospadias, cryptorchidism, undescended testes, or small testes at birth. Childhood. Physical: normal appearance at birth, but taller than average stature with long legs and arms due to delayed epiphyseal closure. Developmental. Mild developmental delays, e.g., speech or motor skills. Learning difficulties, particularly in reading and verbal skills. Social or behavioral challenges, e.g., shyness, difficulty with peer interactions. Reproductive, small testes, often unnoticed until puberty. Adolescence and adulthood. Puberty. Delayed or incomplete puberty due to hypogonadism. Reduced facial/body hair, sparse pubic hair. Gynecomastia, breast tissue development. In 30 to 50% of cases. Physical. Tall stature with eunuchoid proportions, long limbs, short trunk. Small, firm testes, testicular volume typically less than 4 milliliters. Reduced muscle mass and strength. Increased fat distribution, especially abdominal. Reproductive. Infertility, azoospermia in most non-mosaic cases. Low libido and erectile dysfunction. Endocrine/metabolic. Low testosterone, leading to fatigue, reduced bone density, osteopenia/osteoporosis. Increased risk of metabolic syndrome, obesity, insulin resistance, type 2 diabetes. Neurocognitive. Mild cognitive impairment, particularly in verbal processing and executive function. Increased risk of attention deficit/hyperactivity disorder, ADHD, or autism spectrum traits. Emotional challenges, e.g., anxiety, depression, low self-esteem. Other. Varicose veins, venous thromboembolism risk. Dental issues, e.g., toroidontism, enlarged pulp chambers in teeth. Variants. Mosaic Klinefelter syndrome, 46XY/47XXY. Milder symptoms, sometimes with preserved fertility. Higher grade aneuploidies, 48XXXY, 49XXXY. Severe intellectual disability, dysmorphic features, e.g., epicanthal folds, clinodactyly, and profound hypogonadism. Diagnosis of Klinefelter syndrome involves clinical evaluation and confirmatory testing. 1. Clinical assessment. History, delayed puberty, infertility, learning difficulties, or family history of chromosomal disorders. Physical exam, tall stature, small testes, gynecomastia, unicoid proportions. 2. Chromosomal analysis. Karyotyping, gold standard, performed on peripheral blood lymphocytes to confirm 47XXY or mosaic patterns. Fluorescence in situ hybridization, FISH rapid detection of extra X chromosomes. Prenatal testing, amniocentesis or chorionic villus sampling for fetal diagnosis. 3. Hormonal testing. Elevated FSH and LH, low testosterone, especially post-puberty. Normal or low estradiol levels. 4. Imaging. Bone density scan, DEXA to assess osteopenia/osteoporosis. Echocardiogram, to screen for cardiac anomalies, e.g., mitral valve prolapse, aortic root dilation. Pelvic ultrasound, to evaluate testes or rule out cryptorchidism. 5. Other. Semen analysis, if fertility is a concern, typically shows azoospermia. Neuropsychological testing for cognitive or behavioral concerns. Screening for metabolic syndrome, e.g., lipid profile, fasting glucose. Klinefelter syndrome is associated with several complications, particularly if untreated. Reproductive, near-universal infertility in non-mosaic cases, limited fertility in mosaic Klinefelter syndrome. Endocrine/metabolic. Osteoporosis due to low testosterone. Type 2 diabetes and metabolic syndrome. Hypothyroidism, increased risk. Cardiovascular. Increased risk of venous thromboembolism and pulmonary embolism. Mitral valve prolapse or aortic root dilation, rare. Oncological. Elevated risk of breast cancer in males, 50-fold higher than general male population. Increased risk of extragonadal germ cell tumors, e.g., mediastinal teratomas. Neurological/psychiatric. Cognitive deficits, particularly in verbal and executive function. Higher prevalence of ADHD, autism spectrum disorders, anxiety, and depression. Musculoskeletal, scoliosis, joint hypermobility, or fractures due to low bone density. Dental, toroidontism, increasing risk of dental caries. Klinefelter syndrome management is multidisciplinary, tailored to age, symptoms, and complications. Goals are to address hypogonadism, support development, and prevent complications. Hormonal therapy. Testosterone replacement therapy, TRT. Initiated at puberty, age 11 to 14, or upon diagnosis in adults with low testosterone. Forms, intramuscular injections, transdermal gels/patches, or subcutaneous pellets. Benefits, promotes secondary sexual characteristics, muscle mass, body hair, improves bone density, enhances mood/energy, and reduces gynecomastia risk. Monitoring, regular testosterone, hematocrit, and prostate-specific antigen, PSA, levels to avoid side effects, e.g., erythrocytosis, liver toxicity. Fertility preservation. In mosaic Klinefelter syndrome or adolescence, testicular sperm extraction, TEES, with assisted reproductive technologies, e.g., intracytoplasmic sperm injection, may enable fertility. Early referral to a reproductive endocrinologist is critical. Developmental and psychological support. Educational interventions. Individualized education plans, IEPs, for learning difficulties, particularly in reading and verbal skills. Speech therapy for language delays in childhood. Behavioral/psychiatric care. Counseling or cognitive behavioral therapy for anxiety, depression, or social challenges. Management of ADHD or autism spectrum traits with medications, e.g., methylphenidate, or behavioral strategies. Surgical and medical interventions. Gynecomastia, mastectomy for persistent or severe cases, often performed in adolescence or adulthood for cosmetic/psychological reasons. Cryptorchidism, orchiopexy in childhood to correct undescended testes and reduce cancer risk. Metabolic management. Lifestyle interventions, diet, exercise, to prevent obesity and diabetes. Statins or antihypertensives for cardiovascular risk factors. Monitoring and screening. Endocrine, annual testosterone, FSH, LH, and bone density assessments. Cardiovascular. Periodic echocardiograms for valve or aortic issues, D-dimer or clotting studies for thromboembolism risk. Oncological, regular breast exams, self or clinical, and awareness of germ cell tumor symptoms. Metabolic, annual lipid profile, fasting glucose, and HbA1c. Psychosocial support. Support groups, e.g., Klinefelter syndrome associations, for patients and families. Genetic counseling to discuss recurrence risk, low, as KS is sporadic, and family planning options. In conclusion, first described in 1942 by Dr. Harry Klinefelter, who noted a syndrome of gynecomastia, small testes, and infertility. Chromosomal basis, 47XXY, identified in 1959 with advances in karyotyping. Klinefelter syndrome is a complex, multi-system condition arising from an extra X chromosome, leading to hypogonadism, infertility, and developmental challenges. While its presentation varies widely, early diagnosis through karyotyping and comprehensive management, encompassing hormonal therapy, developmental support, and complication screening, can significantly improve quality of life. Despite its prevalence, underdiagnosis remains a challenge, underscoring the need for increased awareness and access to genetic and endocrine care. With appropriate support, individuals with Klinefelter syndrome can thrive, contributing to society in diverse and meaningful ways.